Good afternoon. My name is Janet Frick, and I work with Salt Lake County Aging and Adult Services, the host agency for this year's Utah Elder Justice Conference. I want to welcome you to the Social Determinants of Health and Alzheimer's and Related Dementias session. As an attendee, this session, you will only be able to see the presenter and yourself by pressing on the button on the lower right that says participant. Please ask any questions you have through the Q&A, also located on the lower right hand section of your screen. We will answer questions. The presenter will answer questions throughout her presentation. And I will now turn over the time to our presenter who will introduce themselves. Thank you.
Hi, my name is Liz Garcia-Levitt. I'm a licensed clinical social worker. My area of expertise is with dementia and working with families and caregivers. I work at the University of Utah Department of Geriatrics and in the newly developed Aging Brain Care program as part of the Department of Geriatrics. And this is actually a presentation I was asked to do last fall, where they were looking at social determinants of health, and I was contacted, and apparently people liked it well enough they wanted to see it at this conference. But please, as I go along, I know this may be the end of the day. This may be about the third or fourth time you're getting a presentation about Alzheimer's disease. Please do feel free to throw out questions or comments. I would love to be able to include those to make the presentation more focused towards what you're hoping to learn or hoping to hear kind of with this conference. I often like to start out, kind of just talking about memory loss in general. I've been working in this field for, going on about, 16, 17 years now. And, as my role as social worker or health educator, I've had many opportunities to interact with the public. One of my favorites is to sit down like in a big expo center kind of thing with aging adults, like the senior expo or senior health fairs. And if you're sitting in the chair and above you is that sign that says, memory loss, you suddenly become about the least favorite person in that room. It's really funny to watch, where you'll see seniors kind of going what we like to call trick-or-treating from booth to booth to get candy, and you'll see them often take this big circle to try to avoid you. And I think it's a sign that most seniors are really uncomfortable talking about memory. They're really uncomfortable thinking about, I'm okay talking about just about every other health condition, but I don't want to talk about my memory. The exception to that is occasionally you'll have an older gentleman who will walk up to you and say, I've lost my memory. Can you help me find it? And, I think there's often that use of humor to try to approach this idea of memory. And the other people who come to talk to you are almost exclusively children who are dealing with a loved one who is having some memory changes, or their other loved ones or other caregivers. I love this kind of cartoon on the back. Only Alan was prepared to acknowledge the elephant in the room. If you think about who is Alan, Alan is the guy being sat on by the elephant. I like to think about dementia often, and cognitive change is often the elephant in the room when you're dealing with seniors, and often in our health system. You can have people talking about patients who are, not participating in their care, or patients who are often not non-compliant is what a lot of our medical providers like to use that phrase. And sometimes when you dig into it, you get to, well, they just had a stroke. Maybe they've had some cognitive change. They have other functional changes that may point towards an underlying dementia process, but it's not the thing that everybody's recognizing as maybe being at the root of some of the changes that are going on. Most cognitive change comes on very slowly. It's something often patients and families brush off or ignore the symptoms for many years. Or even if they do go to the doctor, often in a mild stage, memory loss um, isn't necessarily going to be picked up on in a 10-minute doctor appointment. Or if you go see a doctor who knows you for a long time, they may be dealing with your blood pressure during the appointment or your knee pain. They don't often have enough time to, talk about these nebulous other symptoms unless it becomes, the big thing that they're worried about. Um, Other times, what I'll often see medically is we'll see medical records of where patients may have been diagnosed with dementia or have that in their medical record, or even taking medications that are really only approved for people with Alzheimer's disease. But you go to ask the family or the patient, do you know that you have a diagnosis of dementia? And they will have no idea that that's actually part of what they're taking that medication for, or they'll often have no idea that that's something that the doctor was suspicious of. One major problem we have is that it is believed that over 50% of patients never actually get a formal diagnosis. So, I think that's almost incomprehensible for many other medical conditions. You wouldn't have people on their deathbed for cancer and the family still have no idea what's caused it. The idea that if that these are symptoms that have been there present for a long time, but because there was a perception that there was nothing we could do about it, that it just kind of got brushed over, or that families themselves never sought a diagnosis when they're seeing these changes. And we'll talk a little bit about why that may be, but it does have really dramatic impacts on our health system and the type of care that people receive. I think one of the most important points, if you don't come away with anything else, is this idea that cognitive impairments and dementia, these are not normal aging. This is not something that just happens to everybody when they make it to 75 or 80 or 85 or even 90. We know that there are people, I've met many patients working in geriatrics, and I think everybody can think of their own life of people that they've known that make it up to 95 or 100, and they'll often say, well, they were sharp as a tack. And that is normal aging. There are some changes that are common as people get older. Sometimes people slow down. Sometimes, the brain may take a little bit longer to go through the file cabinet. But an actual dementia with function changes and significant memory changes, when you're seeing that, it is not just aging, it's due to an underlying disease process. And so I think it's often one of the main misconceptions that impacts dementia is this idea that, well, it's just grandpa's getting old. There's almost always a cause more than that. And I think that the term dementia can be a little bit confusing for a lot of people. They say, well, what's the difference between Alzheimer's and dementia? What do we, I think grandma had a little bit of dementia, but she definitely didn't have Alzheimer's, because I'm thinking that's something that she had that, that means people are really severe, and that's not what she was. Well, I think in medical terms, we use that term dementia as a describing term. When our doctors say, we think your loved one has dementia, what they're saying is that you've had changes in your thinking, in language or with memory or with judgment, and that change in thinking is severe enough that it makes it hard to do day-to-day tasks. So sometimes we'll have people coming in and, our loved ones will say, oh yeah, they're really bad off. They just can't remember a conversation we had 10 minutes ago. That would probably represent a change in memory, but we always want to dig in deeper and say, okay, how bad is this change? And has it really impacted your day-to-day function? Does it make it harder to manage your finances? Because of this memory change, are you missing your appointments? Or are you having more difficulty remembering to dress or bathe? And so if somebody's just having memory problems, but they're independent, we don't call that a dementia. We call it a mild cognitive impairment. And I think oftentimes people misunderstand when we're talking about dementias and different diseases that it's not all or nothing. You don't go from being completely cognitively intact one day to often having severe symptoms unless there's been a major trauma to the brain. Sometimes you'll see a jump like that, like if somebody's had a severe stroke where the blood flow didn't make it to half of their brain, that or a major head injury, then you could jump from, over here, very mild to a very severe stage. But often what happens is you'll see a slow progression. And there's often this theory of this mild cognitive impairment stage where people are starting to have symptoms. We can show and document in the medical record that there's changes, but if they're still independent to their day-to-day tasks, we don't call that a dementia. We call that a mild cognitive impairment. And dementias and mild cognitive impairment can be caused by a lot of different things. Kind of go back to my other slide. Alzheimer's disease is one type of dementia, but there's actually about 50 others that we look for when people are getting diagnosed. Is this due to a Parkinsonian kind of condition like Lewy body dementia? Is this due to the blood vessel circulation in the brain, like an avascular dementia? Is it due to more than one cause? It's not uncommon for example, Alzheimer's disease and vascular dementia to exist in the same person. And even a distinct diagnosis like Lewy body, when they actually look at people's brain tissue, in about half of the cases where they find Lewy body dementia, they actually find Alzheimer's pathology at the same time. So, these are all conditions that are more likely to happen as people get older, but again, not normal aging. I like this slide that kind of shows what's happening in the brain with Alzheimer's disease specifically. And I talk about that more because it is the most common type of dementia. But I really like this slide that shows the difference between what the brain looks like in a healthy brain and what it looks like with advanced Alzheimer's disease. When you look at the comparison, they figure that about a third of the brain tissue by the end of the disease is gone. And the brain tissue is attacked by underlying causes of proteins, what we believe that are causing damage to the cells, amyloid plaques and tau tangles. The damage starts kind of in the hippocampus, which is kind of the memory centers of the brain. Here you can see a little hole here in the brain that's not present over here. That's where your hippocampus would be. But other areas of the brain also are affected. The front part of the brain, the temporal lobes, the parietal lobes. Inside, the whole brain tends to shrink over time. And it happens slowly, but it happens and often they figure that by the time we can clinically diagnose Alzheimer's disease, it may be that people have lost upwards of 80% of their hippocampus. So a lot of damage has actually happened by the time somebody is at a point where we can clinically diagnose this. That's been one of the biggest challenges with clinical research in the field of Alzheimer's disease, is identifying specific diagnoses in people, but also the theories that, if we're going to stop or slow down the disease, we got to be able to do it at a period of time where we can preserve brain health and not after all the brain tissue's already been damaged. And that's been part of the trick of finding effective treatments. I did want to share this video, and I'll turn over to the other presenter to see if you can actually hear the music behind it, but that tells us more about how common this disease is and how much of an impact it has in day-to-day and in our society as a general.
You see that's the slideshow?
Yes. Well, I guess we're not getting the music this time. the video is somewhat more impactful with the sound behind it, but you can get a sense of what it's saying is basically that, you know, this is an incredibly impactful disease. It impacts more than many cancers, and it's one of the most expensive diseases to our society and to individuals. One of the biggest issues, again, is access to care, and that's where kind of the aspects of social determinants sometimes come to play in. A lot of my content and facts do come from the Alzheimer's Association. They tend to be one of the best organizations to actually gather the data about the disease and issues that impact people with the disease. Let me get back to sharing my slides. Okay. So one of the interesting aspects of the data from 2020 that the Alzheimer's Association just came out with is that they did do a focus this year. Every year they do their national numbers, and then they'll often do a special report that focuses on a different topic. And this last year, they were focused a lot on race and ethnicities and how Alzheimer's disease impacts different communities. And what they found is that, you know, when they questioned different dementia caregivers, over half or more of dementia caregivers of color have said that they faced discrimination when they were navigating the health systems and settings for their care recipients. That's a major problem because Black and Hispanic Americans are more likely to have Alzheimer's or other dementias compared to white Americans. You know, we know that they're out there, that people have dementia in these communities at higher rates, but they are less likely to actually get the diagnosis and get appropriate care. There's also fear about equity, that if there was a treatment, if there was a cure, that Black communities would have access to it. And I think that that's a legitimate worry. You know, the things that are in the pipeline, treatments like aducanumab that is up for approval with the FDA this summer, it's not going to be an easy take a pill cheap treatment if it gets approved. It's likely to be an infusion. It may be a multiple, time infusion. And if you're in a community that doesn't have good access to healthcare in general, or if you're not identified, and this is likely going to be a medication that will be approved for people in that mild cognitive impairment stage or in the very early stages of Alzheimer's, not in the later stages. So if there is a delay in getting treatment or diagnosis, they may lose the window to receive the benefit of the medication. And so it's kind of like a kind of domino effect where if you're not getting good treatment early on, you may miss out on opportunities until it is too late to get those treatments. I think there's also a misconception about dementia or a change in culture. Hispanic Americans are about 1.5 times more likely to have Alzheimer's and other dementias than whites, yet 3 in 10 Hispanics do not believe they will live long enough to develop dementia. And I think part of that's cultural. I've worked a great deal with the Hispanic community, and if in previous generations your loved ones did die of that heart attack at 50, and if you think that's what's going to happen to you, you're less likely to plan or expect the need to plan for long-term care or have the resources saved up for that. But I think we're getting much better about treating a lot of those other conditions that used to take people's lives suddenly, or turning them into chronic conditions, so that people are living much longer, even in these communities, and they're much more likely to kind of be taken by surprise of developing these dementias later in life. And Hispanics, Blacks, and Native Americans are twice as likely as whites to say they would not see a doctor if experiencing thinking or memory problems. I've seen this quite a bit in my in my direct practice where we are happy and are accessible often in our geriatric practices where I've worked to often accept anybody with Medicaid, Medicare, what have you. But often there would almost have to be a carrot or a reason for many minority populations beyond just getting a diagnosis to come in and see us. One thing that I often will see, especially in like refugee or immigrant communities, is they would put off diagnosis to the point where, maybe we have to get mom and dad qualified for their citizenship. And then we've run into this barrier of um, mom or dad can't pass the civics or English requirements for the citizenship test, and now they have to get a doctor to say they have a dementia, so to show why they can't get it. And that has, in multiple occasions been kind of, for some of these populations that I've worked with, been the kind of carrot that's brought them in to see the doctor so that they can actually get a diagnosis or actually get adequate treatment for their dementia. It's sad, but I think we need to find ways to outreach to a lot of these communities better. We know that COVID, and I wanted to add some of this data, we know that COVID has been really hard on our dementia populations. The data, I think, is still coming out to see what the impact has been. But for people with Alzheimer's disease, we're seeing in the state of Utah over 374 more deaths than expected. So 20% more deaths this year than in previous years, likely due to COVID for people with dementia. So, we have this number of 900 in the state of Utah, people who died in 2019. It's very likely that the 2020 numbers are going to come out much higher than that. What is interesting in the state of Utah is that Alzheimer's disease is now the 4th leading cause of death. And we do know it's increasing. Our state is expected to increase with numbers of people developing dementia over 23% in the next handful of years. And it is more common as people are getting older, and as our population is aging, we're going to need more dementia care for this population to meet that demand. What's also interesting about Alzheimer's disease is that other common causes of death have decreased over time. People are living longer with HIV or after a stroke or even with cancers. So of the major killers, we've made much better strides in the last 10, 20 years with every single disease except for Alzheimer's disease. Part of that is that the money that was dedicated in the 80s and 90s and early 2000s towards Alzheimer's disease was just a very small fraction of what like the research money towards cancer or towards heart disease was getting. That's improved dramatically in the last 5 years due to, I think, lobbying efforts by organizations like Alzheimer's Association. But, I've been working in this field for 15 plus years now. We haven't had a single new medication in all that time. We don't have a disease-altering medication, and a lot of it is due to the lack of resources put towards Alzheimer's research, and there was kind of this gap of many years where there really wasn't enough funding to do the research or to pursue the treatments that were thought to be helpful. And this is a shame because even if we slow down the disease and keep people in the milder stages longer, it would have dramatic impacts in the savings towards our society and just in the bottom line of state budgets. Another big challenge we have here in our state of Utah is that we actually have a healthcare provider crisis for the types of providers who provide care for individuals with dementia. In 2019, the Alzheimer's Association kind of did a survey looking at the number of geriatricians or the number of specialists for older adults in the country. And counting in the state of Utah, they figured there were actually 21 geriatricians. in our whole state. To compare that, I was curious, how many pediatricians do we have in our state, or pediatric specialists? And I wasn't able to come up with an exact number, but looking just on the university website in the Faculty of Pediatrics, I was able to find over 300 pediatricians or pediatric specialists. So that's not even including IHC's pediatricians or several of the other unaffiliated, but it gives you a sense of how much of a disparity there is for this type of specialty. And we know that geriatricians have much better outcomes for healthcare, providing healthcare in older adults as well. This is a medical specialty. You know, there's a lot of really good internal medicine doctors or primary care doctors who are picking up the slack, but they often don't have the resources of geriatricians or the specialty or the interest to be able to really provide, you know, recognize signs of dementia, appropriately address the comorbidities, and address challenges that come up medically with these populations. We have only 4 geriatric psychiatrists in Utah, and they're all in Salt Lake City, or I guess Dr. Freimer does see patients up in Farmington as well. But that's a big issue. You know, what do you do if you're in St. George and you're starting to have dementia behavior? When there's not a psychiatrist who specializes in that, you know, people often end up with premature hospitalizations or premature placement in facilities where this may have been a behavior that we could have managed at home or help addressed with caregiver support or treatments. And so the lack of specialty care often plays out in the lives of each of our patients. None of the inpatient geriatric psychiatry programs are actually staffed by geriatric psychiatrists. So what's happening is when somebody's having really dramatic, difficult dementia behaviors, often they're placed in a general adult psych unit. Like, for example, in St. George, you may get taken up to Provo Canyons. Well, you're going to be put in in a unit that specializes in mental health conditions for younger adults. And the providers may not be as familiar with neurological conditions. And for the same reason, it's probably not appropriate to put a 10-year-old in the next bed of a individual who, you know, is detoxing from meth and, you know, violently needs to be in a psych hospital because they're violent. The same reasons that's not appropriate, it's not appropriate to put a frail 80-year-old in that next bed. They're too.
Liz, we have a question.
Please, go ahead.
Cole says, we shared the number of geriatrician data point on the other.
Sorry, you just muted yourself.
Can you hear me now?
Yeah, I can.
Okay, this is from Nicole. She says, we shared the number of geriatricians data point the other day, and a PCP was on the call, sparing details, but it wasn't well received and was extremely upsetting to them. It felt it was critical of their field. Have you ever had this experience? And if so, what was your answer?
You know, I don't at all want to be critical of general primary care physicians. I think that they do an amazing job. I think that the challenge is our health system has told general primary care providers that you're supposed to do this job and about 5 or 10 others. And you're supposed to do it in 15 minutes. These are very, very complicated patients, and often they're the most complicated patients that many primary care doctors have on their panel. They tend to be very time intensive. The benefit of our geriatric clinic and why we can sometimes manage these patients, if not better, but, you know, in a more manageable way, is that we have case managers and we have social workers and we have a pharmacist on staff, and we need every single one of those specialties to help manage that. And that may just be out of the reach of a general primary care practice. And so I don't ever want to say that they're not doing a good job. They are doing an excellent job with the resources that they have. But often, just the constraints of primary care, in the same way where we wouldn't expect a primary care physician to manage the chemotherapy of somebody with cancer, it's not appropriate to expect a geriatrician or a general primary care physician to know all the medications or treatment options for somebody who has Alzheimer's disease. They just don't, they're not trained that way. They're not expected to do specialty care. I think it's too much to ask to demand them to do the type of screenings and testing and treatments of somebody who has dementia when they're not, really set up to succeed in that role. So, I think a primary care home definitely, I never want this to be critical of that. And I think most primary care, when if they have an option to have their patients see a specialist, will often refer to that for many different medical needs. I hope that answers the question. But it is hard because, again, we know the numbers aren't big enough to meet the need. And so what's happening is, as these providers are taking on the load, and they're doing a great job where they can. There are a lot of really rare things that if you're not specialized in cognitive neurology, if you're not specialized in cognitive disorders, it may be hard for a primary care to tell the difference between, is this Alzheimer's disease, or is this a less common condition, or is this actually a mental health condition? The people who are trained and specialized to do that are either specially trained geriatric psychiatrists, specially trained cognitive neurologists, or specially trained geriatricians who've done extra training to do that. Right now, we've about 12, 15 years ago, a large foundation donor saw the need for good dementia care and couldn't find it anywhere in the state of Utah. And so they approached the University of Utah to develop a specialty dementia program. That was the Center for Alzheimer's Care, Imaging, and Research that was developed under the Department of Neurology. And they hired Dr. Foster to start that program up and hired a handful of different cognitive specialty neurologists. Unfortunately, in the last several years, that program has slowly declined, and Dr. Foster himself has retired, and there really hasn't been a specialist in the state to kind of step up to take over that level of specialty care. And so it's an ongoing challenge where we're not training enough cognitive neurologists, and when you get a good cognitive neurologist trained, often they have their pick of centers they want to go to. They're often pulled, different areas. They're given really attractive offers to start their own center, different places, and it's been hard for us to recruit or keep that level of provider here in the state of Utah. And the hard thing is we're actually in a better situation than many of our surrounding states. Our providers will often have patients that come from Idaho or Wyoming or Northern Nevada, Montana, because they don't have any kind of academic clinical centers for dementia care either. So we're kind of the University of Utah and its programs are kind of a magnet for uncommon dementias or younger onset dementias and a kind of specialty care for many of the surrounding states. When we're talking about how a dementia should be diagnosed, I think it's helpful to know, what is a good diagnosis? What can we find when somebody is getting a diagnosis? You'll often hear that sense of, well, why should I bother seeing my doctor when you can't diagnose a dementia while somebody's alive? And I think there's some kinds of misunderstanding about that phrase. Yes, often you'll see people's medical records and it'll say probable or possible dementia or possible Alzheimer's disease. The only way to 100% diagnose Alzheimer's disease is to look at somebody's brain after they pass away and look for the biomarkers um, in um, in the brain at that time. But in the last several years, they've actually developed other types of biomarkers that get us a lot closer, where we can probably say, yeah, we're probably about 95% certain that this is due to Alzheimer's disease, or 90% certain, based on, where we can take measurements of things like the hippocampus in an MRI scan, or we can do specialized amyloid or tau PET scans. Part of the issue with some of these tests is that even if they've been FDA approved, since we don't have a treatment that reverses the disease at this point, it's been a hard thing to convince Medicare, who's probably one of our biggest insurers, to cover things like specialized PET scans in all cases, because they're not seeing the effectiveness of having that answer right now. It's still something that's being battled around, and there's been some really positive breakthroughs in the field of looking for blood biomarkers, and so it might be easier to get Medicare to pay for a blood test that may cost them $1,000 as opposed to a PET scan that may cost them $10,000. So I think this is something that's going to continue to change in the next several years, where all the tests that are there to get a good diagnosis are going to start being more clinically available and not just through research. But right now, our clinical diagnosis primarily, and it tends to give us about a 90% certainty when we compare a clinical diagnosis with what happens in the brain, what we see in the brain after somebody passes away. Usually what it involves is meeting with a specialist who does an in-depth interview with the patient and people who know them. They usually do a medical exam, which includes checking for other reversible causes of memory change. They look at medication problems, blood work like thyroid and B12 levels, look for sleep disorders, mental health conditions that can mimic dementias. They'll do brain scans such as an MRI or FDG PET scan. And then they'll often, as long as the patient's cognitively intact enough to handle it, 4-hour neuropsychological testing. And so I often, when I'm explaining the diagnostic process to families, I'll say, it's like we're putting pieces of a puzzle together. We don't base a diagnosis off of just one piece of the puzzle. We look to see where all the puzzle pieces are coming together, and to see if, as we get all the pieces together, if we can see a bigger picture that would point towards the diagnosis. Is the MRI looking conclusive, looking like an Alzheimer's disease pattern? Are we hearing a pattern of memory change over a long period of time slowly? Are we seeing neuropsychological markers that say that, we're seeing the classic short-term memory changes, or other markers that would point towards an Alzheimer's diagnosis? When we have everything that's kind of saying the same thing, then that strengthens our diagnosis in that case. Part of the reason why it is hard for people to get a diagnosis and why our diagnostic rate is lower is that this process is lengthy. It may be that we see a patient one day and then it takes a month or two to get all the testing, and then they come back and get the results later. It's not, a one and done 10-minute appointment with the doctor. And so the people who often can go through that full diagnostic process by having loved ones who can take time off their own work schedule to come and take their parents to the doctors, or, recognize a problem, they are often disproportionately people who have high income or high health literacy. The patient themselves isn't usually the one knocking on your door saying, I have a problem. Many dementias affect parts of the brain that make it hard to initiate new activities. And so if I don't have get up and go, I'm not going to be the one to make the appointment to see my doctor, even if I'm worried. Or often there's also changes in insight where the patient themselves feels like they're perfectly fine.
Liz, we have about 10 minutes left. Just wanted to let you know.
Yep. And so that's a major issue if, kids are saying there's a problem here, but you go ask, say, Dad, I'm worried about your memory, and he says, I'm perfectly fine. It's hard to push past that sometimes to say, well, no, Dad, you're not fine. Let's take you to the doctor. And so that's another reason for delay in diagnosis. And, again, coming back to, where primary care doctors often don't have the time to dedicate to an in-depth assessment. And there's often a theory about, why should we get this diagnosis if there's not a treatment that makes it go away? In my case, or why I would argue why it is important to get a diagnosis, is because it often impacts our ability to take care of other medical conditions. If we put that puzzle piece in that helps people understand that, or helps loved ones understand, your dad is having problems with managing his diabetes because he can't remember, we need extra help. It often kind of shoots off a light bulb in the kid's head saying, yeah, maybe I do need to be more involved, or maybe I do need to bring in resources or supports. And it often impacts other healthcare decisions. It also, as it is a spectrum, if we can diagnose somebody earlier, we can start the process of talking about planning. What do you want in the future? How can we protect your assets if you may need more care? And the person with dementia is much more likely to be able to participate at an early stage than they are in a later stage. So all good diagnoses should actually be accompanied by good disease education and family support with the development of a care plan. And also, every dementia is not the same. We don't use the same medicines for Alzheimer's disease as we do for vascular or Lewy body dementia. In fact, it's pretty dangerous to use some medications with Parkinsonian conditions. And if we're just saying that, everybody's Alzheimer's disease, we're not going to give the right treatment. There are a lot of things that are protective and risk factors. I'm not going to dig down into this too much. I love to encourage people to read this book, Aging with Grace, if you're wanting to know what we know about risk factors and protective factors. It's based on a study of a group of nuns where this group of nuns dedicated their brains to science after they died, and they were a group of they were an educational order, so they had a lot of things in common. But it's a fascinating read where it talks about, which of this, very cohesive group, what were the risk factors that led to some developing more cognitive changes, and what were protective factors that seemed to be supportive of healthy aging. In general, when I'm talking to families about what we can do to fight back against this disease, I like to use this analogy of a bucket. Our brain is a structure of our brain is kind of like a bucket. And sometimes there's things that cause us to have holes in our bucket, like Alzheimer's disease or a vascular change like a stroke. Some holes we can plug, some we can't. But even if we can't plug holes, if we're trying to keep the level of function up, we can keep adding water. And the things that continue to add water to our bucket are things like physical exercise and mental activities and social activities. So if I can help somebody who's been diagnosed with a dementia get the resources and the environmental supports in place so that they can continue to be socially active, so they can be physically active and continue their passions, they actually have a slower decline from the disease. And they may, continue to have a very good quality of life for a number of years. And I think that that's a major gain, not only for the person themselves, but for our health systems in general, and for the their caregivers. I think other presentations have talked a great deal about caregiving, and these are some of the numbers for caregivers in Utah. Caregiving is definitely a social justice issue, especially for women. 2/3 of caregivers are women. 1/4 are sandwich caregivers, meaning that they're taking care of parents at the same time they're taking care of children. Many caregivers are also older adults over the age of 65, where they may be taking care of a 90-year-old parent or a spouse. 41% of our caregivers have a household income less than $50,000. And over 66% of caregivers live with a person with dementia in the community. So this is often an issue with where these are our neighbors. These are people that are living in our community, not just in a care center.
We have 5 minutes left.
5 minutes, okay. And this is something that we know makes a big impact in their day-to-day lives. Many women and caregivers have had to leave work early, choosing retirement, had to go on, and this is a very expensive disease. In average right now, if you're bringing home, if you're trying to get care for a loved one, you're looking, starting out at $20 to $25 an hour. If you're looking at assisted living facilities, they're usually on average about $4,000 a month. And so these are care costs that our individuals are paying, but also our health system is paying. I'm going to kind of skip ahead, but I did want to see if there was questions kind of before we run out. I'm happy to kind of answer specific questions where you have. I did want to kind of give a plug just to what programs are out there. If you have a loved one or know somebody who has a dementia, there's different programs throughout Salt Lake that do a good job. You know, if you're looking at a patient who's very young, who has an atypical presentation, often the University of Utah Department of Neurology, they often specialize in kind of the less common types of dementia. If you're needing a diagnosis and ongoing care, our clinic at the Department of Geriatrics with the Aging Brain Care Program is actually also provides ongoing care, and we're starting to partner with the UCLA program for evidence-based continuity care. There is a new geriatric psychiatry program through the Huntsman, or what used to be UNI. There's 2 locations, one in Salt Lake and one in Farmington. And there's also good social workers who do cognitive disorder education and family support, both at our clinic at geriatrics and then in the Department of Neurology, and also from geriatric psychiatry. So that would probably be where I would recommend kind of in the state, in Salt Lake, for if you're looking for a good diagnosis or good support. Other good resources that are available, I'm a big fan of the Alzheimer's Association. Senior Blue Books and the 55 Plus book are a good resource. There's actually a free booklet about legal and financial planning for those 55 and older for the state of Utah. National Academy of Elder Law Attorneys. And if people are saying, you know, what are good resources to give to families, these are some of my favorite resources. I love Teepa Snow and her videos. She's an occupational therapist who does an amazing job about explaining dementia in a really understandable way, and also helping families kind of know how to practically interact with their loved ones. If you want to know more about, you know, the importance of care in older adults being mortal by Atul Gawande is something I give to all my medical students. And we hand out because it's probably one of the most readable books that talks about where we're at with our healthcare system for older adults and how we got here. And then Learning to Speak Alzheimer's is a really great guide to knowing how to communicate and adapt activities for loved ones. So any other questions? I think I'm kind of right at the end of my time.
Yeah, I see. I don't see any additional questions in the queue, and we have reached the end of our session and our conference for Utah Elder Justice. I want to thank you, Liz, and want to thank everybody for attending the social determinants of health in Alzheimer's and related dementias. We have concluded our conference for the day, and I hope that everyone has acquired the knowledge that they were seeking. And thank you for participating in today's Utah Elder Justice Conference.